All right. Well, welcome and thank you for joining today's session, Leveraging Leapfrog, Integrating Safety Data into Your Benefits Strategy. I'm Janet Lucas Taylor, the Executive Director of the Business Healthcare Group. And we want to use your time this morning talking about safety data. As we think about that, as employers and plan sponsors are facing rising healthcare costs and significant variations in care quality, incorporating safety data into the benefit design is more important than ever. Today's discussion will highlight how organizations can use Leapfrog's hospital and ambulatory surgery center ratings to guide members towards safer, higher quality care while improving outcomes and overall plan values. We'll hear from Katie Burgraff Stewart, who is the Director of Healthcare Ratings at the Leapfrog Group, and Dr. Ray Tsai, Vice President of Advanced Primary Care at the Purchasers Business Group on Health, who will share real-world examples and emerging opportunities to align benefit design with patient safety. As a reminder, this webinar is being recorded and all participants will be muted for this webinar, but we encourage you to ask questions by using the chat function, and I will monitor that chat and answer questions as we progress. With that, I'll turn it over to Dr. Tsai.
Great, thank you so much. And thank you so much for having me. It is so exciting to be able to present to this group talking about Leapfrog data and our partnership with PBGH, or their partnership with us to be able to kind of show employers how to use it and a whole new use case for it, because I think there's, as one of our members put it, there's no good price for unsafe care, and so the integration of safety data is so important. And I think for us at PBGH, we're also doing a lot of work on transparency in general, and so hopefully this is not just very informative about what Leapfrog does and why Leapfrog is important in the benefits design, but also gives some excitement of different actual real-world use cases of how it could be used with some of the emerging things coming onto the market. Thank you so much for having us. And I'll go ahead and share my screen and get us all started. So, for those who are unaware, I'm part of Purchaser Business Group on Health. We're a sister organization of y'all's. And we are originally the Pacific Business Group on Health on the West Coast, but we've existed for about 35 years, doing very similar things to y'all in terms of advancing quality, driving affordability, and ensuring access. And overall, this is a sample of some of our members, and we represent about 40 members that collectively spend about $350 billion for 21 million Americans. I'll give a chance for Leapfrog for Katie to introduce herself.
Yeah, thank you. And we're thrilled. I'm thrilled to be here and also thrilled to be working with the Purchaser Business Group on Health. We've had a longstanding relationship with for this novel project. So the Leapfrog Group is a nonprofit. We are what we call purchaser driven. So we are founded by employers and purchasers of healthcare, some of which are shown on this slide. And our mission, hence our name, is to trigger giant leaps forward in the safety, quality, and affordability of healthcare. And the way we do that is using transparency to guide those value care. Really, these employers got together and wanted to be, they didn't have that quality information and wanted to be paying for the best possible care at the best possible price, right? Like Raymond, you said, there is no, price for bad care. So the data we collect and publish, it's used by national and regional health plans, employers like yourself, and groups as well as transparency vendors, researchers, policymakers, and then of course consumers. So although we are an employer-driven organization, our data is publicly available. It's used by consumers, and then certainly used to educate employees. So we work with purchasers and employers throughout the country, similar to the Business Healthcare Group. These are really our boots on the ground. They ask hospitals to participate. They ask ASCs to ambulatory surgery centers or ASCs to participate. They knock on the doors of facilities and ask them why they aren't participating. And really, this is how we're able to garner participation in our programs and really drive the needle forward on transparency.
Great, thank you. And so before we dive further into it, I will just do a little bit of level setting, but just very quickly, because I know I'm amongst friends here as part of our sister organization. We all know healthcare costs is rising, right? And we all know this is really affecting businesses and many people in this room. And one thing is that I think over time, there's more and more pressures on employers, almost being like seen as like the last hope of this healthcare system to really drive change. And employers, though, uh, are also taking on more risk for that. So, for those who have been following the CAA fiduciary risk, like employers have always been fiduciaries of their health plan since ERISA. That was part of the point of ERISA to begin with. However, the CAA in 2001 started putting teeth around it to really hold employers accountable for their health plan fiduciary role, just like they have been held accountable for like the retirement plan as an example. However, the thing is, how do you like be held on a fiduciary standard if you have like no information on what's going on? And so that's where transparency became really, really important. And so Leapfrog, we love as a partner because it's always stood for transparency on patient safety. And so now we're adding in transparency of price data, which is exactly what we combined with Leapfrog data to help employers really think through their fiduciary role and how to be really good stewards of that of those funds. And so, and what we're actually seeing in the market is there's more and more risk happening in terms of employers being held accountable for not paying attention. And so the market's still kind of learning how to deal with this. But that risk is growing and that risk is coming. And so I think we just need to be even more vigilant moving forward, which is why work on looking at price and quality and safety is just so important and paramount right now. And so what we did in this particular project that we're going to talk a little bit more about is we talked with our purchaser members about what they felt like they needed to be good fiduciaries on their um, health plans. And then we looked at the current data vendors that would be able to help us with that. And then we piloted with 5 purchasers across 10 regions where their lives were to think through how do we combine patient safety data like Leapfrog that they really wanted, as well as price transparency, as well as quality information to make good decisions in terms of their health plans. Um, and so the ultimately what we did was we made these strategic partnerships with Milliman to help us with our data analytics, with Turquoise Health to get the transparency data, with Embold Health to look at provider quality data, and then of course with Leapfrog as well for the hospital safety data. And then we amalgamated them all into one and presented that to our members to show different benefit strategy that they could take and insights that they would have on their own health plans to be better at giving the best quality care at the most assured or reasonable cost to really drive value in their health plans. And that's what this is all about. Uh, Ultimately, we have two separate outputs from this project. One is publicly available, and so I invite you all to take a look. I warn you, the main white paper is like 178 pages long. I kept calling it my PhD thesis. And also we're doing more advocacy in terms of wanting to be sure that we continue to drive transparency in the marketplace. Also, what I'm going to give you a little bit of a glimmer of today is what the individual employers got. And in terms of what they saw on their own reports related to their spend and the safety of their employees and the care that they were receiving. That being said, the employer side, the previews I'm going to give today are just little snippets, but they're not completely what the employers got because they got things that were based off of their own claims data, and that obviously is not something I'm gonna share on a webinar without them being here. And so but overall, for those that are interested, there are two white papers about the transparency about this project. One was the thesis project I was talking about, which was introduced in October of last year, that showed all the different prices in the 10 regions for specific codes, overall hospital pricing linked with some Leapfrog scores, and just kind of drew out some general trends, which, spoiler alert, the general trend is there is no trend. It's just completely nonsensical. And that's a lot of what the reports that looked at our work ended up talking about. And then also, I think one of the main parts of our pilot project was just trying to figure out, like, could we make the transparency data leverageable for employers? And so the answer is yes. And how we got there is in the second white paper that just looks at more the methodology of what we did with the transparency data, because a lot of the discourse around these federally mandated transparency files has been like, oh, they're not usable, there's too much data, they're too dirty, they're not standardized. And so what we really wanted to do was show that, no, we can use it, and let's start using it to drive better value in the healthcare system. And so this is how this second white paper is more of a methodology one for those that like to dig into the details. But let's get to the results, because I think that's what's the most interesting. And then what we'll do is we'll go through the results generally, and then I'm going to hand it back to Leapfrog to talk about how we layered in Leapfrog data on top of that, what we're planning to do in the future with Leapfrog data that I'm really, really excited about. What we did, and this is more of a graphic of what I talked about before in terms of working with Milliman and Bold, Leapfrog, and then also layering in the employer claims data and putting all of that together. There was a lot of cleansing, validating, and integration that had to happen. And so then we worked with our employers to really pull that together in a way that made sense to them. And we heard very loud and clear from our members that this is not about just driving members to the lowest cost providers. Like, that is not what they want. They want to drive them towards value. They do not want to drive towards lower costs that risk patient safety. And so one of those things that one of the first moves we made was to bring in Leapfrog data because of that, so that those decisions could be made with safety in mind. And then we also gave employer-specific reports based off of utilization and other kind of outliers we might have seen in their claims data. Some of the early findings that we found was that, one, as we know, the early adopters of price transparency data were health plans and providers. And so I would really encourage employers and purchasers to really think about using this data because otherwise it's going to be used against you. And so that's one thing that we noticed. That the other thing is there's a little bit, goes in more detail into the papers, but we found a lot of issues with the files themselves that I kind of talked about that's already in the public discourse. But what we learned was employers did have the opportunity to talk to their health plans about how to make the transparency data better and more actionable for employers. And I think that's really important for all of us to do because I think it should be all of our missions to really drive transparency in the healthcare system so that y'all know what you're purchasing, consumers know what they're getting, and everybody kind of sees what is going on. And it's also one of the things that's needed for a functional marketplace. Um, and the fiduciary risk of data quality is real, just so people, just to lay it out very, very clearly. The final rule in the transparency and coverage uh, kind of rulings is that it's ultimately the responsibility of the plan or issuer to provide the information required. And so the health plan might be the one producing the reports on your behalf, but ultimately, this was very clear in their FAQs that it is for self-insured employers, it's your responsibility to be sure that that information is correct, and so that becomes if so far there's no enforcement of this, but the enforcement when it does happen, they made it very clear it will fall on employers. Um, and so we took that to also help our members through this project to really work with their health plans to improve that data so that if and when overall. And as you can see here on the right-hand side, this is in one of the publication, the data quality does vary quite a lot depending on where you are. And so we have from Oregon and Northern California and Southern California, those are the on the left-hand side of this graph, pretty unusable data, like almost in Oregon down to like 30% that was maybe usable in terms of what was reported by the health plans. And in Denver, it was a lot better, and Seattle Puget Sound was a lot better. But it's kind of good to know like where in your region you might be affected by not having good data. And also, if you don't have good data, you can't drive good decision making. So that's another part of it. Um, Now, when you do have good data, though, so we're going to look at an example from Seattle Puget Sound. This is specifically from the health plan provided data. What you can start doing is then start comparing different health systems and different payers in your market in terms of general prices. And so what we see here, and again, Seattle Puget Sound might not be relevant to this audience, but if you extrapolate a little bit, what we're looking at is in the first yellow box, what we're seeing is that uh, the multi-care system in Seattle, they're generally within each health plan contracting for similar rates. That's what you would expect, or probably, but that wasn't always the case. There were many systems that we saw throughout the Transparency Project where we saw health plans individually um, uh, contracting for different rates, even within the same system. And so that could drive some benefit decisions or strategies. The other thing you kind of see, and I'm really sorry to throw them under the bus here, but like Swedish Medical Center was generally just more expensive than others in the market, and that's also probably good to know if that's some hospital that's highly utilized in your plan. And so this, as you can see, can start giving some visibility in terms of what each individual employer is paying, and then also be able to compare it across different health plans, right? So if you have, as an example, um, a high utilizing population at Swedish Medical Center, sorry to pick on them again, and you're on Aetna, then you're paying a lot more than other payers in the system, and that might be a reason to act on that somehow. And so, so this gives a lot of visibility that can drive strategic decisions within the health plan kind of strategy. What we then did was also we took the provider quality, and so we used in bold. We're not uh, endorsing anyone necessarily, but we used in bold. And what we did is we grouped them based off of provider group, and then we were able to see based on provider group what their overall quality was to see if that justified the prices that were being charged. Because ultimately, I think employers, if patients are safe, if patients are getting good quality care, that might be worth a higher price. And so this allows people to look at both price and quality. And so what we can see here, as an example, is that even some, let's just say some entities in the market that we would expect higher quality care sometimes had a lot of bifurcation of quality as well, in terms of a lot of high quality providers, but also a lot of providers that maybe weren't meeting the mark as much. And so that also uh, is just something we should be aware of to know where our members and their families are accessing care, because we obviously want them to be accessing the highest quality possible. Finally, the last thing I'll bring up is this is also from Seattle Puget Sound, but the use of transparency data allows you to finally do benchmarking in a market. I know with our members, some of the whom want to do direct contracting or just want to monitor their plan, they'll ask questions like, well, how much should a hip replacement or a knee replacement cost? Like, we're paying this much for it, but is that right for our market? And so what we did in our 10 regions is we did look at the median price for these procedures in that market, so that would help at least answer the question, like, what does this cost in each market? And this type of work is typically not very available previously, and so the transparency data allows for this, and allows for different thinking. Also, really interesting here is you can also see the difference between the price of outpatient facilities for a hip replacement, and the bottom two is the ambulatory surgical center for the same procedures, and that price difference really is only based off of site of care. And so site of care type strategies is something that I know we've, as employers, have thought about a lot, and this gives a little bit of a numerical value towards that. Now, I've went through all the different data in terms of the transparency data and the provider quality and the a little bit of the employer claims, and then now to add the final layer, I'm going to hand it over to Katie to talk about hospital safety data.
Thanks so much. So the Leapfrog Hospital Safety Grade is just like what it sounds like. It's an A, B, C, D, or F letter grade. It was incorporated into this project, and it's focused exclusively on patient safety. So it's biannual in the fall and spring, so that we can provide the most current data available. And it focuses on things like accidents, injuries, errors, and prevention of those. So things like healthcare associated infections, patient safety indicators, healthcare acquired conditions, things that should never happen in the hospital. Um, Use of medication safety, like use of a barcode system or computerized physician order entry that can alert you to prescribing errors. And we use all of that data, 22 measures, to assign a letter grade A through F. And that's regardless of participation in our hospital survey, which is a voluntary program. And I'll talk about that a little bit later. And we do that because we want to have this information on as many general acute care hospitals as possible, regardless of their efforts to be transparent. So we're able to do that using our survey results, data from the Centers for Medicare and Medicaid Services, as well as other secondary data sources like imputed scores. You can go to the next slide. So we make all this available on our website. So I've pulled up some facilities in the area, and what this really shows is that it does matter what facility you choose. There is variation, and your outcome and quality of care can vary vastly based on what door you walk through. And the safety grade is focused on things that are important or things that should never happen to any patient, regardless of the population served. So, no patient should have a foreign object retained when they go in for a surgery or get an infection that they didn't come to the hospital for. And we are transparent. We ask facilities to be transparent, and in turn, we make this all available on our website by facility. And I should mention, unlike other programs like the Centers for Medicare and Medicaid Services, we know that employers and consumers, their employees, they're choosing specific facilities. And so we make that data available. Um, CMS is rolling that up at sometimes the system level, but you're not shopping for a system. You're really shopping by facility, and we see great variation in performance among those facilities that are under the same system. So not only do we make that letter grade available, which was included in this program because it's a really easy composite of these 22 measures, but in consumer testing, they were actually interested in all of the measures and performance on those that get included in your score in the safety grade. And thank you, Janet. You can go on the website, hospitalsafetygrade.org, and look up facilities in your area, look up facilities in your family's area, populations where your employees are located. And next slide. So why does this matter? Based on research at Johns Hopkins Armstrong Institute for Patient Safety and Quality, we know that patients at a D or F hospital face a 92% greater risk of avoidable death compared to an A-rated hospital. And from there, it's 88%. B, even the difference between an A and B is 35%. To the point that, if all hospitals had an avoidable death rate equivalent to that of an A facility, 50,000 lives would have been saved based on the time period of this data. So safety matters. It does matter what facility you choose. It's why we make this available by facility. It's why we're thrilled to have this included in this project, because price is only part of the information. We know that costs go up exponentially if you have a healthcare associated infection. And, of course, you want to make sure your employees are going to the best possible care. So what else? More to come on the future of this program. But in terms of Leapfrog and what we make available to employers, we have also the Leapfrog Hospital Survey and the Leapfrog ASC Reporting Program 2.0, which I'm really excited to talk about. So the Leapfrog Hospital Survey, a bit different. It's voluntary. We have over 2,500 hospitals participate. It's annual, and not just focused on safety, but also quality information, resource use, and it's applicable to all hospitals. So you're going to see children's hospitals. It's going to include things like maternity care, a big spend for employers certainly. And we work with expert panels to establish national standards for performance on each of the measures included. And we report that publicly, which I think on the next slide, we have an example of how we do that. Great. So you can search for a hospital. You can also search for a surgery center, which I'll talk about in a minute, and can see their performance by measure. We report it out in performance categories such as achieve the standard, considerable achievement, etc. And that's all based on those metrics that we determine with our expert panels. So you can see that here. This is an example of maternity care. This hospital is performing, really well across the board, but perhaps not as well on, preventing blood clots in cesarean births. So, that would be worth following up with that facility about. All right, and then our ASC public reporting program. We started asking surgery centers to participate in a voluntary survey based on really a request from our members to have this quality information. They had price information. I loved that previous slide where you showed the cost differential between a hospital and surgery centers. It's extreme, right? I even know when I'm looking at my health insurance, I'm going to pay a lot less as an employee if I'm going to that surgery center, but I don't know about the quality. There's very little national data. And so we look to solve this problem by launching our ASC survey, and it has been a struggle. While we are a household name among hospitals, it's been a lot longer track for surgery centers. It's a different structure, right? Some of these surgery centers are one-person shows. They don't have a quality department. The person that's maybe walking you through the door and getting you ready for surgery is the same person that would be asked to fill out this survey. So we are completely revamping the program this year. And the way we're starting it is with CMS public reporting. We have more data from their ambulatory surgery center quality reporting program. It's not accessible really to consumers or to employers, employees. It's all, you have to download data sets, convert them. It's not easily understood. It's not searchable. And it's not compared to any kind of reasonable benchmarks. They have, compared to the national average, really. Are you doing better, worse? So we'll have that data. We'll put it on our website. And then this kind of like this path forward. If a facility chooses to, which we hope they will, they can upload an accreditation certificate. So facilities are accredited from HHC or the Joint Commission. And they can build trust by having even more patient safety information on our public reporting website by uploading their accreditation certificate. And we can be assured that they are meeting certain standards for various measures. All of this has allowed us to really focus on just a few measures on what we're calling our ASC Survey 2.0. Really reducing the burden of participation. And this would be an additional thing that ASCs could voluntarily submit this information. So at a minimum, we are going to have CMS public reporting data for all of the surgery centers across the US. And for those that optionally, upload their accreditation certificate and even go further on uploading their, reporting on the survey, even more information, really adding value to the data that we have available, coupling that with the price information so that we can really get a bigger picture of performance in the ASCs. So I mentioned most of this, but it's going to include 13 CMS data. There are a variety of 5 measures that are aligned with accreditation standards. We've reviewed them and have been able to replace those with our own survey measures. And then there's an additional measure for surgery centers that voluntarily submit, and 8 additional measures, for those that voluntarily submit our survey. Of which I should mention, we have about 100 facilities that currently participate. So if we go to the next slide, we're going from 100 to over 2,500 surgery centers. Really exciting. You'll be able to search on our website for free. You can go on there and you can compare on our website up to 3 hospitals and or surgery centers. You can compare hospitals to surgery centers for, there's measures where they align, and search by procedure, and really have a vastly, just a huge number of ASCs that you're going to have information on, which we've really never had before. We do have a tool, because this is a lot of information. We have a lot of measures where you can get information on. So we have a measure search tool, and you can look up what measures are available for hospitals and surgery centers. Not everything is going to be applicable to a surgery center. We don't have maternity care data for surgery centers, for example, but you're going to be able to see where it's aligned and where you're going to find that data, and actually how many years. So you can see things like our never events policy. We've had that in our hospital survey for 19 years, whereas some of the other measures like healthcare equity are a bit newer. All right, so I will turn it back over so that we can talk a little bit about how that safety grade is integrated, and definitely at the end open to any questions that folks might have.
Yeah, and so I'm so excited for this new ASC data because what we did already do, and for those who look at our publication, we have this for all the 10 regions that we looked at. We lined up their Leapfrog safety grade with their pricing information in every single market. And it allowed our employers to do a few things, one of which one employer was using the quality and safety data to help their health plan with certain negotiations that were happening on the provider side, because the provider entity was wanting to justify a certain price, but did not have the quality and safety data to necessarily justify that price. And so that was used within that negotiation. The another thing that one of our employers saw was they saw that a lot of their members was using a hospital that was well, it's at the start of the project, it was a D rating, and there was a few meetings about that. So now they're at a C rating, and I'm not going to name which one, but there's still a lot of talks about that. And because to them that's inappropriate, and so they went to that hospital leadership and and talked about their safety grades. This goes even beyond for some of our members that are doing direct contracting, where they put as part of their direct contracting the need to participate in the Leapfrog data, because I think in the end it's all of our responsibility, and it should be all of our desire to be really working together towards pushing transparency in the market for patient safety, because we want to be able to be sure that we are able to justify the types of the levels of care that are being paid for. And we want to also, just on a human level, make sure that our employees and their families are getting the best quality care and the safest care, because it actually matters at a individual patient, at an individual human level. And so the kind of the takeaway and why I'm so excited about the ASC data now is that we're going to be able to do the same thing that we did here now on the ASC side, right? Because if we're going to be moving from trying to do site of care types of strategies due to that very high cost differential for there is going to be a subset of patients where it's appropriate to not have it done at an outpatient hospital and have care and surgeries done at a ambulatory surgical center, but only if we can be assured by their quality and safety. And so it's that combination that really can drive meaningful decision making. And so excited. When we last tried to do this, a lot of the ASCs, as Katie mentioned, didn't have a rating. So we were like do we try to drive our patients there? Do we not? And so now with that data, we can do that with the feeling of responsibility that due diligence was done to ensure that the patient safety was considered as well. And so overall, what we've proven is we can use the transparency price data and combine it with quality and safety data and present it in a way where employers can have concrete decisions and have a very strong strategic goal for it. And so that's ultimately what this is all about. It's not an academic exercise of like, what is the safety grade? This is about impacting for the better real life decisions. And so that's what we really want to be doing by combining price and quality and safety data together and really develop a really functional healthcare market that's going to drive affordability, really for employers, of course, but transparency helps everyone, right? So we really want to do it for the entirety of the healthcare system. And so there's so many different things that we can do when you're combining price, quality, and safety in terms of benchmarking. I talked about some of the strategies of COE and steerage and direct contracting. It's also just being able to keep an eye on your partners and right. And so as I kind of mentioned, sometimes there's certain partners that might be negotiating for something, but if they don't have the safety and the quality and the outcomes to match with what they're trying to negotiate, that's something we should know, and we should be, holding people accountable for that. And then ultimately, this will fall in terms of fiduciary risk for employers in the future. And so the and I've talked a lot about safety in terms of how that impacts the individual patient, and so is Katie, and that is really important. Just as a reminder, like looking at affordability also impacts the individual employee and family, right? Like uh, low value care means unjustified out-of-pocket costs for employees as well. It also translates into wages. Like we hear a lot about how wage growth has been stagnant. Where's all that money going? It's a lot of it's going to healthcare. And so this is these things are fundamentally important beyond just the health plan, as well as better health outcomes. And also, I mean, everyone's providing a benefit for their employees. So let's make sure it's a benefit and good. And that's also what employees and families want as well in terms of workplace satisfaction. And so with that, I'm happy to take any questions.
Thank you, you guys. There's one question that just came in. What issues surfaced as you began evaluating MRFs from different payers and TPAs?
That's a loaded question. Let's say, okay, let's put it this way. Uh, Overall, I think the the each individual pair had different quirks as to what was difficult about their files. And so I would say the overall type of gestalt was that a lot of the health plans, and understandably so, I don't necessarily fault them for this, is that they were trying to go towards compliance of the rules. And so, because of that, they did not think about how do you make this data actually usable for employers to actually make decisions. And so we actually had one of the employers of our members call in the CEO of the health plan that they were engaged with to talk about like, no, we're supposed to be using these files. You have to do better, and they are now doing better. But some of the very, very common things that we saw that made it a little bit annoying was multiple rates for the same code. And so ultimately, employers want to know what rate are they paying or supposed to be paying for that code, not every single code that exists or every single rate for that one code that exists within a health plan's like all their contracts. Like that's not helpful for the employer. The employer needs to know on our plan what is our rate. And then the other thing that we saw a lot of was that there was one health plan that tended to use custom codes for things, but didn't define what those custom codes were. But in their system, I guess that's how they bill. And so then, so you would have a code called ABC for, let's say, an emergency room visit, and you just don't know what code ABC means and how that like compares to the other health plans in the market. So that was another very common thing. And then I think the very third common thing is that there was a lot of kind of ghost codes put in there for like let's say a there would be a code for or a price for a psychiatrist delivering a baby as an example or something, and they would just like throw it in there in their report, but the psychiatrist doesn't really deliver babies, so there's no like actual there shouldn't be a price associated with that, and but because of that kind of changes how you look at the data by having some of these fake prices in there. And so so those were maybe in the three big buckets of things that we saw.
Thank you. Katie, I know, thank you for posting the CDC numbers on hospital-acquired infections. And, Bruce kind of pointed out it's about a million a year. And I don't know if you have any other comments on infection rates or anything else that we're seeing in the market related to safety and the Leapfrog measures.
Yeah, so with the healthcare associated infections, just to add on that, those are included in our safety grade. We've had several reports that we've put out that really align also with reports from the CDC and others showing that healthcare associated infection, that the prevalence has actually gone down. So yes, that is a lot. It's not where it should be, but it has gone down significantly. We saw really a peak during COVID. And then it has come down, and in some cases below kind of the baseline level. Um, and yeah, I would encourage you to read those reports. Also, the CDC publishes, I believe it's each year, a current progress report in healthcare associated infections, which is what I linked to in the chat.
And then we have a question on how do we get more ASCs to fill out the survey.
I love that.
And I know we also may want to know how we encourage hospital systems in our area to also participate in the voluntary Leapfrog survey, which I think many Wisconsin hospitals do not participate currently.
Yes, so participation in the state is about 25%. Compared to, some states which have 100% participation. So how do you get facilities to report? A commitment to use that data in your education, in your contracting, showing facilities that you are using that data is really going to encourage participation. And that does require commitment. It requires communications with those facilities, knocking on their door. I mean, don't be afraid to have a meeting. You're paying for the care that you, negotiate with these facilities, and you should demand, quite frankly, better care. So that continues to be an important way, again, using the collective power of employers to get facilities to participate. And that's really how we've been able to increase participation. For ASCs, it's kind of a different barrier. Of course, it still remains important to be using that data and asking facilities to participate. I think the biggest barrier there has been the burden of participation and just not quite understanding Leapfrog and how the data is used. We are trying to solve that with the ASC Survey 2.0 to the point that even if they don't do a survey, we're going to have information reported from them. And I think what we'll see, of course, yet to be seen, we'll see in July, is that, once they do see that their results are reported, regardless of their participation, they would be interested in sharing more data. And certainly we've made it a lot easier by letting them upload an accreditation certificate, and then reducing those measures that need to be self-reported. But really a great question. We really need all of you to continue to push for participation.
Thank you. There aren't any other questions in the chat. I spoke way too soon. Thinking ahead a few years, what is your forecast for the impacts, positive and negative, for advances in AI? And what is the premise and the perils of utilizing AI, probably related to safety and quality, I would guess.
Yeah, I'm not sure if that's which of us is a question for, but this is something we're continuing to look at. And work with our various advisory panels. We've had conversations at at our meetings. And really, we work with hospitals, CEOs, variety of quality directors to understand what is, happening in those facilities in terms of AI. In terms of, data, I think there will be interesting ways that AI can, really take data and see things that we just can't. And certainly we'll see more and more of that. But certainly, there's a lot of things that, AI can't be used for and that we have concerns about, in terms of answering patients' questions, or, there's still issues with using AI to help with charting or what have you. So, it remains to be seen. Right now, we are just kind of in that phase of getting as much information as we can and trying to understand how the, healthcare system is using AI.
Yeah, and I would add, so I'm family medicine, so and I still see patients, and I think there's AI a lot on the clinician side as well. Charting is one of those issues or areas that was brought up already. Some basic, I think we're starting to see a lot of. I mean, previously there was always a joke that patients would use Google. I think now they they can use AI to start looking at things, and there's pluses and minuses there in terms of how that ends up being rolled out. And used by patients for symptoms or health concerns. There's also on the data side, or even on the provider side, if I keep going there's a lot of things on diagnoses, on education, on going through some initial data points. We see that in radiology, and so there's actually a lot going on the provider side, and then on the data side, right now, a lot of the transparency data, cleaning and extrapolating is actually quite manual. I think as we learn to use this data better, and toward Laurel's question, what are the common things? Once we learn those, we can probably have AI really help us sort through that data a lot faster. But I think, yeah, AI is going to transform our lives overall in all sorts of different ways. So hopefully that answers the question.
Thank you. And then maybe as we prepare to close, maybe one final question from me. Ray, are there plans to take what you're doing in the demonstration project and actually kind of look at that from an evaluation and the impact on outcomes for members and outcomes for plan sponsors?
Yeah, absolutely. And so right now, last year, all we were doing was like, can we use transparency data? The answer is yes. And so now our employer members are actually using it to do different things. Our medical RFPs as an input there to get around discount analysis. They're using it for direct contracting it. They're using it for COE developing, all of which also should take quality and safety into account, which they are with by integrating this data in. And so that's what we're doing right now. And then once those implementations happen, we'll have a lot more information in terms of ROI and whatnot. But at the very least, and I say this about primary care too, is let's just say cost of care is flat. If you're getting a better experience, more safety, and better quality, still totally worth it, still a win. And so that's really what we're doing right now.
Wonderful. Well, on behalf of everyone participating, I want to thank you both for spending this time with us today. I think the work you're doing is really important and very meaningful. We appreciate it. And to all the participants, thank you very much. We will be posting the recording and PDF copies of the slides. So if there's any other questions, don't hesitate to reach out to myself or Jennifer here at the Business Healthcare Group. Happy to help you. So thanks, everyone, and have a fantastic rest of the day.
Thank you so much.
Thank you so much.
Thanks.